Thank you again for joining today's Health Education and Learning Program webinar, First Steps and Next Steps in the Transition from Volume to Value. In this session, we'll look back at where we've been and how to put all the pieces together to successfully move the needle towards value, exploration of why rural healthcare providers should be engaged in the transition to value, as well as 3 key areas to focus on to jumpstart the transition. With that, I'd like to welcome our speaker, Tammy Norville. Tammy Norville is the Technical Assistance Director with the National Organization of State Offices of Rural Health. Tammy joined NOSOR as a Technical Assistance Director after serving rural safety net providers for almost 15 years in the North Carolina Department of Health and Human Services Office of Rural Health. As a University of North Carolina at Chapel Hill graduate, Tammy brings a myriad of experiences and expertise to her role, including leadership development, facilitation of collaborative partnerships, program and regulatory compliance, coding, billing, and documentation, and capacity and skill development for State Office of Rural Health and stakeholders. Tammy maintains certified professional coder instructor, certified professional coder, registered medical coder, registered medical biller, and registered medical manager certifications. We feel so honored to have you with us again today, Tammy, for the 3rd time in this series, and I will now turn things over to you.
Awesome. Thank you so much, Angie. I really appreciate it. And hopefully I have my slides correct, so you guys are seeing the presentation and not my notes. So Angie, if I have that backwards or something's weird, just let me know. But thanks for being here, y'all. I'm not going to spend a lot of time on the objectives. Angie told you those beautifully, but I would like to say a special thanks to NOSOR's longtime partner, the National Rural Health Resource Center, for providing the opportunity for me to be with y'all today and the last 2 sessions. We value our partnership with them and hope that if y'all haven't had the opportunity to work closely with these folks, that you will take this opportunity and reach out to them for future partnerships and assistance. They are awesome. There's a little bit about me, and you guys that have been here the last 2 sessions have seen Rider and Buster. I am a fur mama, and I am proud of it. As Angie told you, I'm the Technical Assistance Director for the National Organization of State Offices of Rural Health. We are the member organization for the 50 state offices across the country, and you can go to our website and see all the cool stuff that we do and that state offices do. That link is there for you. I'm not going to spend any time talking about what state offices do. Just know that they are your one-stop shop for all things rural health in your state. The important thing to know is that we are all working towards the same goal. The folks that we serve are generally older, sicker, and poorer, but our goal, the why we do what we do, is to make our rural communities more well, and the way we do that is through the power of rural. And the power of rural was created to put a focus or a spotlight on the uniqueness of rural and specifically rural health. November 18th of this year, it's a Thursday, 3rd Thursday in November, is National Rural Health Day. If you have not celebrated before, this is a great year to start. You can go to powerofrural.org and learn all about National Rural Health Day and the power of rural. But I want to start with our question of the day, which has been the same for the first 2 sessions. Why? Why? Ask why. Why do you do what you do in the way that you do it? And what does that have to do with value? I'm glad you asked, because helping our patients become more well is why we do what we do, and how we do it is important as well, and that is where value comes in, and we demonstrate that value through the building blocks of our business. So if you think of your business, your rural health clinic, as a puzzle or a building that you're trying to build, Lincoln Logs. When I was little, I was all about some Lincoln Logs and Tinker Toys. Loved to build stuff. think about parts of the business as building blocks or components. And you need all of those components to accurately and completely tell the story, which is how you get to value, right? But today, as we go along, not only is why important, we've hit why pretty hard in the first two sessions, but I'd also like you to think about what, as in, what's in it for me? Now, that sounds kind of selfish, doesn't it? But as a rural health clinic, it's really important as you guys that are responsible for the business, it's important for you to think about what's in it for the rural health clinic. What's in it to make you more sustainable? What's in it to ensure that you're providing the highest quality care for the patients that you serve? Because those patients are not just patients. They're not just a number, right? They're your neighbors. They're the folks that you see when you go to the grocery store or when you're pumping gas or at the softball game. So making sure that you're making the best decisions and engaging in not only the why, because the why has always been there. We've always done what we do the way we do it because we're trying to keep our rural communities more well, help them become more well. But really think about what's in it for the rural health clinic. What's the benefit of spending any time on this transition to value? I don't know about you guys, but work is crazy these days, right? And rural health clinics, I feel you. Vaccine confidence grants were due, and some of us had never done a federal grant before, and that was something. We had less than 4 weeks to turn that around. So why, in the midst of all that, Joy, would you spend any staff time? That's a resource, and it's a valuable resource, right? Because when the providers aren't happy because they're working all the time stressed out, or your team is stressed out, why would you spend any time on this transition to value? We're really going to look at that today, and I hope when you leave here today, you have a couple of little nuggets that will help you see kind of why we're talking about what, if that makes sense. So I'm going to fly through some of these slides, the next few, just to remind us of kind of where we are. CMS says that value-based programs reward healthcare providers with incentive payments for quality of care. And they're basically looking for the triple aim, right? Better care for individuals, better health for populations, and lower costs. For CMS, that's their three-part aim. And then, of course, the Medical Society, you'll remember Institute of Medicine, sorry, said that one wrong, came up with STEEP. Safe, timely, effective, efficient, equitable, patient-centered care is value-based, right? That was the original definition. That's a pretty good definition. If you can hit all 1, 2, 3, 4, 5, 6 of those qualities, you know that your services are going to be of value. And that kind of morphed a little bit into the triple aim, which is better patient outcomes, improved patient satisfaction for lower costs. And now we're to the point we have the quadruple aim, which is basically the triple aim plus healthcare professional well-being or satisfaction. So that's where we started. And then, of course, we have a more simple, if you will, definition that really focuses on 3 areas: payment incentives, rewarding value instead of volume; coordination and integration of clinical services focused on prevention and wellness; and information sharing. If you can take all of those other definitions and break them down into 3 focus areas: payment incentives, coordination and integration of clinical services with a focus on prevention and wellness, and information sharing. That's what we're going to do. We're going to take a small bite and just see what the deal is for rural health clinics. And it's always important to remember how you get to value, right? How do you demonstrate value? You do that through your clinical documentation for medical necessity, right? And remember, medical necessity asks 5 questions. What service is needed? Why are we performing the service? How will the service be performed? Who will perform the service? And where will the service be performed? So it is the what, why, how, who, and where of the encounter of that patient visit. And remember, we're focused on an approach designed around patients for improved health, quality delivery of care, and lower cost of care. So patient-centric, focused on improved health, helping your communities become more well, the quality of the delivery of care. So were folks satisfied with the way care was provided, and lower cost of care. So medical necessity is demonstrated through complete and accurate documentation. It's the heart of the story of the services provided, which ties directly to value, to those outcomes. And always remember, medical necessity is demonstrated in this clinical documentation, which is the first component or building block that to our story and to our business. It's the cornerstone of the business. So let's dive into the meat of our time together today. We have 3 key areas in the transition to value. And remember, we're thinking about them in the framework of what's in it for me as an RHC. So what's a payment incentive, right? What does that mean? I don't know about you, but anytime I get money, I definitely equate that with an incentive. It makes me want to do whatever it was I did before to get the money, right? Or to get the prize, or to get whatever. It's in this case, it's really talking about something above and beyond the, using air quotes here, you can't see, the regular or normal reimbursement. And the second question that ought to pop into your head is not only what is it, but how do you get it? So there are all kinds of payment incentives, right? They're generally called alternative payment models or methods, depending on who you talk to. And there's a list here, and this is actually from the Health IT Playbook. They have a really nice, concise list and talk about these payment incentives and payment models in a way that someone like me that's not well-versed in really complex reimbursement models can understand. So, you know, part of what's in it for RHCs, obviously, is payment incentives. You might be asking yourself, how does that play against all-inclusive rate? I'm glad you asked, and hold on to that question. We're going to come back to it. But I'd venture to guess that at least some of y'all are already participating in some type of payment incentive, probably an ACO or an MCO, maybe an episodic payment situation or bundled payment situation, or some other value-driven payment structure. If you operate within the all-inclusive rate system, why should you care about any other payment incentive? So I want to take a quick look at 2 of these. The first one is ACOs. Do you guys know about ACOs? Are you participating in an ACO? Feel free to stick comments in the chat. That would actually be great. But for our purposes, an ACO is a group of providers, whether they're physicians or hospitals or health systems, whatever, that come together voluntarily, and that's the key word, voluntarily, to provide coordinated, high-quality care to their patients. Of course, what else would they come together for, right? The goal is to provide patient-centric, right care, right time, while avoiding unneeded service duplication with reduced medical errors. So, interestingly, ACOs generally take the triple aim and tweak it a little bit for their own purposes, right? So an ACO is, or an MCO, there are lots of different names for this kind of organization, and coming together, we're going to take care of this many lives, 10,000, 20,000, 1,000, depends, lives, and we're going to provide comprehensive care for them. And we're going to provide comprehensive care that we meet or exceed certain benchmarks. And when you meet or exceed those benchmarks, then there may be some bonus incentive funds that could come your way. So that's cool, right? You're probably thinking, okay, yeah, or maybe our state Medicaid is set up this way. Maybe you accept private insurance, and as part of some of your private insurance folks are in a particular ACO. Is that good or bad? Honestly, it probably depends. It depends on if you're really good at hitting benchmarks, right? It depends on if you have good processes in place, solid processes that help you attain the benchmarks that you need in order to make the incentive. And then we have episode payment models, right? These you may or may not have participated in. Some folks call them bundled payments, and it was developed to move with the sole intent of moving providers away from fee-for-service, and moving providers towards, driving them toward more coordinated care. So an all-inclusive payment gets issued to cover a certain code set or certain services that you're providing for that patient. So then what's the key? Controlling cost, right? So the more you can control cost, the more potential savings there is that you might share. Shared savings. Does that freak anybody out? Yeah, just a couple of things to consider about these payment incentives. Tips, do your homework. Make sure you really understand what you're getting into. It would be very easy to back yourself in a corner, if you will, and when in doubt, err on the side of caution. How much risk is too much risk? That's something that you have to look within your organization and determine. Something to consider other than doing your homework. Doing your homework is a tip and something to consider. The other thing to consider is make sure you understand any agreements for signature, meaning contracts. If needed, find a consultant or trusted advisor. If the financing is complicated, find yourself a good CPA or good financial consultant that can help you. If you need somebody to help with contract interpretation, find that trusted legal counsel. The main thing is, Rural Health Clinic, you don't have to do it on your own. There are people that can help you. If you are thinking about considering entering into an agreement, you can reach out to your state office of rural health. They can help connect you with partners that might be those trusted advisors for you. You have the folks here in the RHPTP program. They'd be more than happy to help you. Just make sure that you are paying attention and understand what you're agreeing to in contracts. So, what's the deal? What's in it for me? So you might already be involved in an ACO or other alternative payment method that might lead to payment incentives. If so, yay! That's awesome, but what if you're not? You know, there are ways to dip your toe into the value pool without jumping into the deep end with shared risk and other scary terms. What about chronic care management? You've heard me mention that in an earlier session. Not exactly a payment incentive, but it is reimbursed outside the all-inclusive rate. And I'd wager that you're already doing the work. You may not have the process in place with all the I's dotted and T's crossed, but you're doing the heavy lift already. Which leads me to our next topic area, models of care. So there are all kinds of models of care that are conducive to value-based service delivery. So remember we talked about one of the four models of care. It's coordination of care, specifically looking at prevention and wellness in addition to treatment, really focusing on improving outcomes. You notice that the NOSOR simple definition and the Health IQ playbook, we have lots of similarities. How do you go about integrating and coordinating care if you're not already doing it? Most of you, I would venture to guess, are already doing it. So for models of care, the way rural has always provided care is parallel to the descriptions of value-based service delivery. We are patient-centric. That's always been the approach, hoping to promote provider satisfaction because happy providers stay put, right? Providers that aren't happy are the ones that you end up having to find somebody new. Value-based programs have strong infrastructure. We've talked about components and operational efficiency. So all of those things work together to tell the story of the way your rural health clinic provides care that is of value, does meet the definition of value-based care. And so it's not just the treatment and the coordination of care and looking at prevention and wellness. It's also looking at cost effectiveness, especially for folks with chronic, complex, or extensive conditions, right? And here's a little list of 5 bullets of ways that value-based care comes at being cost effective. So limiting duplicative and repetitive testing, decreasing unnecessary emergency department visits, improving patients' quality of life. How do you do that? Chronic care management. What, you say? How does chronic care management improve a patient's quality of life? I'm so glad you asked. Think about chronic care management and the things that you're talking to the patient about during those like 20 minutes or more over the course of a month. You're probably talking to them about, are you taking your medicine? Are you taking your medicine as directed? Are you eating the way we talked about? More greens, less frozen meals? Did you get rid of that rug that you were tripping over? Improving patients' quality of life. It can be the little things, but the little things add up to big things, right? So I'm going to come back to my question. As a rural health clinic, what's in it for me? And what's the benefit to spending any time on this transition to value? Like I said, RHCs already provide patient-centric care. It's in our DNA. You've got that part. A move toward value-based care delivery is a move toward a more comprehensive way to delivering services to our patients. It's an intentional refocusing of the focus of our care, if you will, using all available technologies, code families and service types that are allowable to enhance patient services, improve outcomes, control costs, and ensure provider satisfaction. So what's in it for RHC? Happy providers don't leave. Happy teams remain. Happy patients remain. And the last one of our three focus areas is information sharing. What, pray tell, are we talking about? So the intent here is not just regular old information sharing, but data sharing, real, relevant, pertinent data that can help us tell our story of value. It can help us tell our story of the patients we serve. Why is that so important? Because in an alternative payment method, you have to declare, if you will, the types of patients you have. And you might have heard of risk weighting, where you look at a pool of patients and determine how to weight any particular risk for that group. So sharing information is becoming more and more and more important, right? And as we're a more mobile society, it's even more important that information be shared. I think everybody has bought into this philosophy over time, but pertinent health information that impacts care delivery across the care team is what we're really talking about. There are special considerations when you talk about sharing information and data, though, right? HIPAA comes into play. How well versed are you with the intent of HIPAA rules? And notice I said the intent of HIPAA rules, not how well versed are you in HIPAA. Why did I put it that way? Because HIPAA is not intended to put you out of business. HIPAA is intended to protect confidential information, private information. So just a couple of things to think about when you think about information sharing. Again, do your homework. Understand the pros and cons, and especially of your particular electronic health record. Different health records, you share information different ways. So the one piece of advice I can give you is know when you need to seek outside expertise. Be confident in what you know, but find a trusted advisor for things you don't. And understanding potential risks. And again, when you're considering if sharing information with an ACO or with a payer is in your future, understanding what potential risks are there will allow for mitigation before anything happens. So you're being proactive instead of reactive. It's imperative you know your technology. Not only know your technology's bells and whistles, but know its limitations and understand those limitations. And finally, understand HIPAA and where you're falling in HIPAA and what the requirements are that might impact information sharing. So what's the big deal to rural health clinics for information sharing? All of those things that I just said are very important to consider as you're looking at information sharing. You guys might be in a position where you're already sharing information. If you're a provider-based rural health clinic, I would venture to guess you share information with your parent hospital regularly. If you're part of a health system or even a network, you might be sharing information back and forth because maybe patients go from one practice to another. How does that impact your business? Or does it impact your business? If patients have choice, they definitely have increased patient satisfaction. But understanding potential risk in information sharing. On the news almost every day, there is another cyber attack. Be smart. Understand your computer system, understand your electronic health record system, understand how your connection to the internet works and how protected it is. Do you operate on a VPN? If you save information to the cloud, how secure is it? Is it HIPAA compliant? All of those things need to be considered, even as a rural health clinic. So information sharing, from my perspective, being a rural health clinic or being a fee-for-service clinic, those two types of providers need to have the same kind of consideration, if that makes sense. So let's talk about some next steps. So we went through the payment incentives and a few examples of that, and models of care, and information sharing. Those are the three focus areas, right? But what are next steps? How do you take the first step to move you along on the road to value? First of all, is there clinical support? Do your providers support this transition from volume to value? Why should they be interested in this shift from volume to value? One, because it's the right move for the patients, right? Because ultimately, value means you are patient-centric. Even though we've always kind of rolled that way, being patient-centric allows us a different perspective when we are thinking about patient care. Having providers understand that and lean into that and embrace that philosophy, once you have that clinical support, then support from the rest of the office and patients will follow. So the second thing to think about is what processes, and included in processes, I'm including policies. So policies and procedures need to be reviewed or potentially revised. What about chronic care management? Let's talk about that for a second. We said that's a way you can dip your toe into value, right? So I need to put a process in place to make sure I have all my I's dotted and T's crossed so I can actually bill for chronic care management, because we do that work. What processes do I need to examine? Are there policies that need to be tweaked? Are there procedures that need to be tweaked to make sure that we're in compliance with all of the requirements around chronic care management? And then we can bill, and then we can get reimbursed for what we're doing. The third tip I would give you is, do you have a clinical documentation improvement plan in place, a CDI? If you don't, I would strongly encourage you to explore what a CDI is, how it's used, and the potential benefit for you. So in a nutshell, a CDI is having somebody, usually an outside person or entity, come in, do a chart review. And notice I said a review, not an audit, because they're not really auditors. But they look at documentation, provider documentation, against what was coded, against what was billed, against what was paid. Looking for gaps, looking for ways that documentation could be more accurate and complete. Because remember, if documentation is the cornerstone of the business, if your documentation stinks, your coding is going to stink, your billing is going to stink, and therefore your reimbursement is going to stink. So we really need to make sure that our documentation is where it needs to be. Not only to support our current coding and billing efforts and telling our story, but moving into value, it's going to become more and more important to be able to demonstrate value through that clinical documentation. You'll see an increase in chart reviews by insurance plans because they're wanting to make sure that they're getting the most value. Their return on investment is where it needs to be. If you have questions about CDI, feel free to drop them in the chat, or feel free to send them to me directly or through Angie, and I can get you some links to some information about CDI and how to go about developing a plan that's right for you. Because the other thing about CDI is it really needs to be individualized to your organization and your providers. I believe in meeting people where they are. So if you have providers that have been providers for a while that document a certain way that may not be as complete and accurate as we need, they may need to be, they may need a little more TLC than some of, let's say, the newer providers that are a little more flexible with their documentation and embracing of change. Okay. So when you think about payment incentives, just a couple of other things to think about. 7 questions. What's the type of arrangement? Who's offering it? How's performance projected? Are there associated expenses? If yes, what are they? Potential impact during this transition on volume and fee-for-service revenue. What do you think the transition is going to be? Might be a little painful. So you have to plan for it. Make sure you have a little nest egg. And looking at sensitivity, whether scenarios are viewed as optimistic, moderate, or pessimistic. You're looking at particular patients. Again, this number 6, think of it as back to the weighting of risk. And then the last question is probably the most profound. What's the cost if you do nothing? What's the cost, or what's the potential cost to your rural health clinic if you just ignore value? Any thoughts on that? If you do nothing, what is the worst case scenario? Well, if you believe some folks, if you did nothing after some period of time, Medicare or CMS may take action for you to not be a provider anymore. Now, in reality, do we think that's going to happen anytime soon? Probably not. Could it happen? Sure it could. But the cost of doing nothing could be extremely high in the future. Maybe not tomorrow, maybe not a month from now. But the cost of doing nothing for your patients, the cost of the rural health clinic not doing anything to your patients might be catastrophic, right? Because what if there's a practice, not necessarily a rural health clinic, but what if there's a practice that decides, you know, our care is not patient-centric. Our care doesn't really take the patient and their individual life and being into consideration. Just to think about. So what is your next step? What's your first step? Have you taken it? Are you convinced that value is coming and we need to prepare? We need to, at a minimum, get our toe in the pool, but we can do that in a relatively safe and comfortable way through services like chronic care management and transitional care management and principal care management. We have avenues to get us moving in that direction so we're not left behind. So I want to talk about engaging for a few minutes. How do you get rural healthcare folks to engage? So we've learned and we know that the why we do what we do and the way that we do it is because we're helping our patients and communities become more well. That's why we do what we do. And we tell that story through documentation, and we've talked about the 7 components of documentation: history, physical exam, medical decision-making, nature of presenting problem, counseling, coordination of care, and time. We've talked about, in January of this year, that time was given a little more importance, for lack of a better word, that providers can use time if they need to help with their documentation and to lean on that a little more. But there's also an emphasis on number 3, the medical decision-making. That's where complexity and intensity are described. That's where care meets value. That's where it's demonstrated. That's where medical judgment comes in, that clinical judgment that if we don't document it well, if we don't make sure that our documentation is as accurate and complete as we can, then we've kind of missed the boat, because documentation is the cornerstone of our business. There's a solid line from clinical documentation to reimbursements received. That has a direct impact on the financial viability of a practice. It also could have a direct impact on the perceived value of the services provided in that clinic. So if you're in an ACO and you have a negotiated per patient rate, should the documentation not support that rate over some period of time, the rate could be adjusted. Remember that risk that we talked about. A lot of the incentive payments are net zero, if you will. So for those that do really well, meet all the benchmarks, provide outstanding care, and do it for a great cost, they get payment incentives. But that means there are practices that didn't do so well, that patient satisfaction is not where it needs to be, and they may have lost money. So that's an important concept to understand. That's why I mentioned, when in doubt, be confident in what you know, but find a trusted advisor for what you don't. Don't feel like you have to go into any of these scenarios on your own. So documentation is the cornerstone of the business. That's how we tell the story of the value that we provide. And like dominoes, you've probably heard this before, incomplete documentation leads to incomplete coding, leads to incomplete billing, leads to incomplete reimbursement. It's all tied together. So clinical documentation is tied to financial viability of the organization. And we understand that this solid line correlation between documentation and reimbursement, even now under volume, could be quadrupled even under value. So don't forget our healthcare equation, right? So basically, value is determined by outcomes, improved outcomes and patient experience divided by cost. So quality divided by cost. That puts a number on your value. Is that a pro or a con? Could be both, right? So, kind of final pros and cons. Value-based care is patient-centric. That's not new to rural. That concept's been around for a long time. That's how we roll. Other pros are it's coming, whether we want it or not, which is also a con, right? It's coming, whether we want it or not. For those that do well, that are able to meet benchmarks, value can be a very lucrative thing. The con is it could be potentially punitive for those that don't meet or don't have the ability to meet benchmarks. Additionally, there is some upfront expense in system redesign, policies. You might have to have technology upgrades. There is some expense up front, and we talked about in the transition from volume to value, there might be a period of time where reimbursement is wonky. That's the technical term, right? Wonky. So making sure you have a nest egg, making sure that you have a way to float the business, if you will, until the process is solidified. So as a rural health clinic, again, what's in it for you? Can you answer that question now? Can you think about, yeah, you know, maybe we can dip our toe in with chronic care management. Maybe we can dip our toe in with principal care management. Just moving in that direction. The first step is always the hardest, but the first step leads to the next step. So making sure that you have embraced why you do what you do. The why you do what you do is to help your patients and your rural communities become more well. And the what's in it for me is the how do we make sure that our business, our practice that serves this community so well and has for whatever period of time, how do we make sure it's sustainable over time? And there are ways to do it without jumping into the deep end of the pool if you are hesitant to do that. If you're not hesitant to do that, hey y'all, let's go. And you have folks with the RHPTP folks that are here to support you in that endeavor. If you're a little more conservative and would rather err on the side of caution, they're still here for you to help you dip your toe in, to help wade into that pool to make sure that the water is not too cold. But it is time for rural providers to prepare for these quality-driven programs that directly impact value and therefore reimbursement. So in making all the pieces fit, we talked about using data from the EHR to tell the story of the services you provide. That demonstrates your value because every service has a purpose or you don't do it. It's demonstrating that medical necessity. It's the why, how, and what of the service, and that connects directly to value. Because if the service is medically necessary, and if the service can help the patient move towards better patient outcomes, that is the direct connection to value. And in doing that, we've taken all of those pieces of the puzzle that are scattered all over. We've brought them together and made a complete and accurate picture of the services that we provide and the value, the return on investment, the quality that we provide to our patients. And it all starts with documentation as the cornerstone of the business. So just remember that value-based care is really moving away from volume, and we're moving towards an approach that is patient-centric for better health, quality delivery of services, and lower cost. And our three focus areas, payments, incentives, models of care delivery, and information sharing. I hope that today you've been able to kind of grab on to at least one tidbit that maybe you can take back and implement to take that next step, to take the first step leading to the next step. And just for good measure, one more time, remember, documentation is the cornerstone of the business. If you have interest in a clinical documentation improvement plan, please don't hesitate to reach out. The other thing to remember is it does take a village. This is my very favorite picture ever. It does take a village to be successful in this transition from volume to value. It takes your entire team. So don't think if you're the CFO or if you're the provider or if you're the office manager that it's all going to fall on your shoulders, because it really does take everybody working together to ensure that quality services are provided and that costs are contained. So final questions, what is in it for your rural health clinic? And is it enough? What's in it for an RHC? Is that enough to encourage you to take the first step towards patient-centric value-based care delivery? That's the question of the day. And if you have more questions, don't hesitate to reach out. That's why we're here. So final thoughts, thank you so much for learning with us. This 3-part series has been awesome. I've really enjoyed being with y'all, and I hope that you've gained some nugget that works for you, that you found value in the time we spent together. I would encourage you to tap into your state office of rural health. When you don't know where to go, they are the one-stop shop for rural health expertise in your state, and that's why we're here. Contact information for me is at the end of the slide deck. You can go to nosor.org and find your state office of rural health, and it gives you contact information. Not sure we have time for questions, unfortunately, but if you have questions, don't hesitate to send them or put them in the chat so Angie can get them, and we'll get you an answer. In the slide deck, there is a list of resources. Don't hesitate to use them. That's why they're here. And again, special thanks to our longtime partner, the National Rural Health Resource Center, for providing this opportunity for me to be with y'all. I can't tell you how much I value their partnership. They're awesome and always a great source of information. And I hope that you guys can continue your partnership with them through the RHPTP program and beyond. Thank you so much for being here. I appreciate your time and attention, and I hope you found some value in our session today. And we have 2 minutes left, Angie. She has
Yeah, thank you so much, Tammy. Thank you for bringing us full circle today and putting these pieces together and helping us move that needle towards value. I have put a poll question on the screen. If everyone could take just a second to answer that. The next HELP webinar, the role of social determinants of health in value-based payment models, a rural perspective, will be held on July 22nd, 1 to 2 p.m. Central Time. Let's see, if you would like the ACHE credits, I have put the link to the survey in the chat box. We encourage everyone to take the survey. But if you want the ACHE credits, you will have to do that We will email the certificates out, usually within a week after the webinar. Thank you for that poll question. I've got one more before you leave. As always, we encourage all of you to reach out to us with any questions that you may have. Reach out to Tammy with any additional questions that you may have for her. Thank you again, Tammy. We really appreciate the time you spent with us this month in sharing your knowledge and expertise in this area.
My pleasure.
With that, thank you everyone for your participation. Have a great holiday weekend, and we will see you again for the next webinar, June 22nd. Have a great day.
Thank you so much, Angie.
Thank you, Tammy.
Y'all take care and have a great holiday.
Thank you, you as well.
Bye-bye.